Devil of Night, in the man, a care removed, break into one for. And this wealth contacted our some train of them. So I was actually also the and powers he tenders seemed to really hospital and it showed partner and saying that maybe huge and all ring the help we enter and to thank every wit to make work. Thank you. Other comment?
I just think that is this to me on my half was came the rest of the ring for help and maybe her health and getting around so she's need to start new stuff.
Yes. Any other comment?
Maybe on that one. A couple of over sales downs to see they might try to Ross protect options use that are to provide specific terms of service seem to be hurry people to him and do I'm right here, but I can start with people who are trying to help. There's a thing.
Mayor North, any comment? I want to go in it. Have a motion of this February 23. Some John Newton. Commissioner Seth Oliver. Motions. Okay. Anyone in the room or public like a cut? You're done. Move with what's in. Okay. So that.
Me, budget by for me as February 20th, remember people more they'll time to start the lot just out prior. No, okay, then we can stuff. I know that I had the run because that's showing is from goes to start sign. The and get just big. For all things look really can it's an finish some things. I'm eating wild look over and some sorry, because when it's still early really and no interest. So it's we connect because those fall line.
Court constant. Essentially,
LCB cases take their medication as well as pediatric latent cases. So as you see there, that was about 500 in-person visits and about 850 video visits. So in a nutshell, those are the services that we provide around tuberculosis. Next slide, please. So specific to this Uniting for Ukraine, what is that? So we were provided funding in the amount of about $31,000. This was pass-through funding from CDC, came down to the state, and they are disseminating that out to LPHAs right now. Contract period, as you see up there, from January 1st to September 30th. This is essentially identical to the funding that they provide. If you recall, we get about $90,000 every year from CDPHE, and that scope of work with this is identical, with the exception is that we agree to share data with them, and we agree to delineate which labs were done for folks coming in from Ukraine. Other than that, it's essentially going to be identical to the work that we do. Next slide, please. So why are we getting this funding? If you might recall, about 2 years ago, we did have an influx of Afghan nationals into our country, into our state, and into our community, and that was a pretty well-organized process. They were quarantined on our military bases for 30 days. They were able to get all their health needs met. They were not released into the community with any communicable diseases of concern. This is sort of in stark contrast to this Ukrainian situation, which of course does not have the organization behind it that the Afghan situation did. And so ultimately, all of these visitors coming in from Ukraine are required to, as it relates to TB, a minimum of getting a TB quantiferon blood test done. That is not required that they come to us for that. They can actually get that anywhere in the community, but some of these folks do end up here at Public Health. Beyond that, it's like, what do we do with that positive blood test once they have it? And of course, at that point, they are eligible to receive services with us. So ultimately, what the CDC, in my opinion, is doing is they realize these folks were not budgeted for. We were not expecting them. Nonetheless, they have come here to our community, and we needed to serve them and to keep our community safe to make sure that there was no concern around active TB. So this is almost retroactive in that we've already seen a lot of these folks, and so CDC is now saying, we've kind of gotten on the ball. We have this funding available, and we want to disseminate it to you now because we understand that you've already been doing the work. It had to be done regardless, and you had no funding for it, so we are able to come in now and provide that funding. So ultimately, this helps, in terms of being able to test and evaluate these folks. It helps us to identify any TB concerns and, of course, keeps our community safe as well. Next slide, please. I think this is my last slide. So just to give you a snapshot, as I mentioned, the minimum bar is that everyone coming from Ukraine does receive this TB blood test within 90 days of arrival. And so what has the direct impact of that looked like for us? I do want to highlight again, they are not at all required to come to public health to do this, but we do have a public health lab that does offer this quantiferon testing. So we've received, I think it's 10 now, referrals involving nationals from Ukraine. We've evaluated 5 of those. You might ask why we have not evaluated the other 5, and there are a number of things around that. Pretty fluid group of people. They're moving to see different family members, moving in and out of our jurisdiction, so some of them are not accessible. Of those, we have identified 3 that have latent TB, including 1 pediatric case. And so those are the folks that are at risk. So they're not infectious. They can't spread it to anybody, but they are at risk for developing active TB at some point in their life. And so we are currently treating them to minimize that risk, and hopefully they will not develop active TB. Do you have any questions or concerns that I can address?
Commissioner Gonzalez?
Thank you. My question is, so do we have a list of all the arrivals or only those that have come in to get tested?
Right. So only the people who have come to public health to get tested. And that can be a challenge because, and this came up in a state call yesterday, other counties are saying, well, even from a public health point, we'd like to know this list of people so we can reach out to them and say, hey, here's an opportunity to get this testing. That number is very hard to come by. I don't have it, and the state doesn't have it either.
Okay, so that's why I'm asking this question. That needs to be done. Whoever's in charge of that, listening at the state level or federal level, that needs to be done. We need to know who they are so that we can do the right thing and get them tested and make sure we're protecting all our residents. So I don't know who's in charge of that. It needs to be done. Thank you.
Can I just follow up with Commissioner Gonzalez? So if I understand correctly, then it's those who self-identify are the ones that we will address.
Correct. So these would be folks that presumably all of them have been told, hey, your minimum bar as it relates to TB, I can't speak to the other stuff, is you must get this blood test within 90 days.
Okay.
We don't care how you get it. It's obviously you got to have a physician order for it. So some folks have friends here who know a physician, or they can go to Peak Vista, or they can go to wherever.
Okay.
Of that group, some of them are like, oh, we should go to public health, or they might be tied into Lutheran Family Services, who's aware of our services. So unfortunately, it's a subset of a subset. They're like, happen to show up on our doorstep. Right. I cannot give you a good indicator of how many folks are out there in this community trying to get this blood test. There is no reasonable mechanism that I can tell.
On the other hand, it sounds to me like as someone comes through customs and passport control when they're coming into the United States, that they're identified and they somehow are captured with, you need to do this.
Exactly.
If the flight is coming from Kiev.
Right. They should be someone out there, certainly at the federal level, must have a list of, we have 500 Ukrainians here, and these are their names, et cetera.
Right.
It is surprisingly hard to get that information.
Welcome to the government.
Yeah.
Right. That's what's...
Okay.
Yes, ma'am.
Commissioner Bremer?
One quick clarifying question on that note. So we don't know that we're seeing all of them, but once there is a positive test, regardless of the organization that does it, that information is reported through to CDPHE, correct?
Yes.
Okay. So, so we should be able to maybe extrapolate what percentage of the overall local positives we are seeing.
So latent TB is not a reportable condition under normal circumstances. I can tell you categorically that there are no active TB cases associated with, frankly, the Afghan situation or the Ukrainian situation. Active TB is reportable, so regardless if we ever saw them or not, and they ended up at Peak Vista, say, if there was a concern around active TB, that is within 24 hours reportable to us, and we follow up on those folks. If they are determined to have active TB, then we do a contact investigation and talk to everyone in their family, everyone in the apartment complex, everyone in their work, and so we identify those folks as early and as soon as possible.
Thank you.
I have
Yep.
something. Susan, Director Whelan?
I wanted to just provide a little bit of broader context. Can you hear me?
No, okay. So some broader context. We are responsible to monitor over 60 different reportable diseases 24/7. And I do want to provide that context as it relates to if there are situations where there would be an infectious case and it doesn't matter, where they're from or existing living here or any reportable disease, our folks are working 24/7 as part of our agency responsibilities and statutory requirements. So I did want to provide some of that context because there is a broader scope to this, and our
communal disease staff, and our tuberculosis staff are phenomenal, and they take their jobs very seriously. As we continue to move into the future and through COVID and also after, we're seeing some complex situations, but I will tell you that my team is very serious about the role that they play, and they are working 24/7, depending on what disease that might be,
Thank
to
you for your
limit and
support.
control the spread.
Yep.
So just to understand, a physician needs to order this screening test. They understand what the purpose of the screening test is. If the screening test comes back positive, there are very standard steps they take next to ensure that the individual doesn't have symptoms of infectious disease. So they do symptom screening, they do a chest X-ray, and if any of that is abnormal, they're going to end up in our shop, because at that point, the physician's going to handle it. Most sole private physician committee will not manage active infectious TB. They're going to hand it over to public health because they're different resources. And they take medicine every day. We give them the pills, so we own that. When they have the non-infectious version, meaning they got exposed to TB, it could be years ago. The TB took, I maintain the infection, but I'm not sick. It's quiet. 90% of people stay asleep for the rest of their lives. 10% wake up. And sometimes they might not do that until they're much older. They have other underlying health conditions that sort of force the TB to wake up. And at that point, they may become infectious. And again, they'll get screened. And so this is, we try to find the non-infectious type of TB infection to get ahead of it. And we get ahead of it. Immigrants and coming from a lot of TB. And so we know to screen, right? We know to and pass it to the other resources we have in our past. But if a physician is going to be ordering this test, it is wired as part of the United States for a country that has TB. This is that's right. And then if there's anything abnormal. So there's some intentional. So we're not at the federal level. We're in pre-production of immigrating for so I hear a concern on understand some redundancy. They will possibly send a traffic and
In fact, that's Dr. Goodman.
And did you have a comment?
So yes, the confirmed TB test we create an automated and patients are referred to test.
It is. It's like a laboratory test would supported by, so remember the little test on your arm. That's the way we do it. It's a little bit, the blood is better. So we try to get the blood. But it's like a blood count, like we're asking one physician to get, and process our blood. So we try.
The scan patients are referred to tested if we show SB test to testing order that we have to do that for patient.
Being out of the health part.
Correct.
Yeah, I've heard reasons to look up and we've seen that Eric is very nice. But get a sense of.
And whereas public health agencies have a responsibility to assess data and provide objective information and resources to support individuals in making the most informed choices for their unique health needs. And whereas El Paso County Public Health continues to meet the needs of the community by forging innovative cross-sector partnerships and strategies to support individual and community health and improve health outcomes. And whereas El Paso County Public Health works to reduce barriers and increase easy access to resources, developing innovative service delivery models to meet people where they are. And whereas it is more important than ever to celebrate public health, support and advance the mission of public health, and continue to acknowledge and appreciate El Paso County Public Health staff for their work and dedication to keep our communities healthy. Now, therefore, be it resolved by the El Paso County Board of Health that the week of April 3rd through 9th, 2023 is proclaimed as National Public Health Week in El Paso County, Colorado. Moved, seconded, and adopted by the El Paso County Board of Health at its meeting held on March 22nd, 2023 in Colorado Springs, Colorado.
Thank you, Lori. May I have a motion to approve the proclamation?
I'd like to move to approve.
Dr. Turbush moved to approve the proclamation. May I have a second?
Second.
Commissioner Bremer seconded. All in favor?
Aye.
Aye.
Any opposed? Thank you. Motion passes. Now we have the director's report.
Can we do a photo of the proclamation?
Photo? Sure. Sure, if you'd like to. Yeah, that works. Susan?
Okay. Here we go.
Have all staff up here, please? Anyone who's in the audience?
I just,
Dr. Mayor, Becca,
all I ever do when the baby's.
this is about you all.
I don't cheer.
And our team member also.
They'll find it.
We couldn't do our work without you. Have you on speed dial.
22.
You all move.
Yes, you all should be in the center. Get in the center.
Here, find someone. Find someone to Have a chair. You guys want to sit together?
Otherwise, what?
Yeah.
I'll mention it. Sure. Thank you, everyone. I have a few words. I'm sorry. I have a few words about that. Okay, Director Whelan would like to address the proclamation with a few words. Thank you. I want to mention that we, before the Board of County Commissioners, first week of April, on our regular meeting Tuesday, to have a proclamation. We are also working with the City of Fountain to do a proclamation, and with our new Board of Health member, Mayor Land, we work with Palmer Lake, and then also the city of Colorado. So we're trying to get around, given that El Capitan's pretty vast, and we're extremely excited that we're able to go before leaders in various different communities and showcase the work of Lake Health. Thank you, Susan. Okay, now for your direct report. Okay, I have a few things before we get to some presentation submission. I wanted to point out the article that was recently in the Gazette. Dr. Kelly and I heard an interview. Much of the interview wasn't used, but we did talk about what we know after COVID and provided some of the information. They had interviewed a public health director from Tri-County, and Tri-County is no longer formed. They have 3 different health departments, and then Dr. Samet from the School of Public Health. But I did want to mention that article, and you saw the headline, but I think if you read through the article and with some insights from our agency, is that we've had a very resilient team. We continue to work on our team and make investments, but with the national standards as it relates to attrition, our agency has fared pretty well with some of that, and some of it was expected as it relates to some of the staffing and some people retiring and resigning and moving around. So we did provide some insight into that, and we also talked about the future as it relates to where are we going now, and where have we been focusing our energy on. As you remember, we had the majority of our staff involved in the COVID response, and so we shifted a lot of our work to the response, and therefore we had limits on our programs, or we had even ceased some of the services that we provided. And so we have been ramping those up and fully open as it relates to all of the different services that we provide, and staff, I think, are doing a great job. One of the key aspects that we have been focusing our attention on is our statutory requirement to develop a community health assessment. And Board of Health members, you all were invited, and some of you were able to attend the Board of Health session where we went in depth about the community health assessment. Our public health planner, Megan Haynes, had provided an overview and insight into a lot of the data that our Healthy Community Collaborative has been reviewing and prioritizing to develop that report. I expect that report to be finalized in May, and if all goes well, we will plan to have a public event where we will share the data and help folks understand the why behind the importance of understanding the data and what that means to our community as it relates to action steps that we can take. I don't think that there's going to be any surprises there as it relates to some of the topics that we have been facing as it relates to substance use, misuse, as well as suicides and suicide prevention. And so we'll get into that a bit more, but I did want to flag you to that. You all will be invited, and I will want probably one or some of you to have a role within that. And I would love to have it in the Board of County Commissioners Centennial Hall with many of our different partners. And Dr. Albanese and Dr. Kelly also will be presenting, and Dr. Kelly's coroner's report will come out at the same time. And so we'll integrate that data to share with the public. And so I think that's exciting, because as we talk about public health's responsibility to assess data, we should be able to offer data that is easily accessible and translatable for organizations and communities doing their work. And we are also working on a few different visualizations of data dashboards. You guys all remember how valuable the COVID dashboard was. We are working on an opioid dashboard where you will be able to filter out fentanyl and other opioids, as well as a all ages suicide data dashboard as well, so we can have insight into unfiltered information for all of us and our partners and community to work from. And then also when media are wanting information, they can go directly to the dashboard and they don't have to make calls, and we're following up. So that's going to streamline the process. And I anticipate that those data dashboards are going to go live sometime in May. And we have worked with all of our county partners on that, such as the district attorney's office, Michael Allen, Dr. Kelly, the executive director with the county for Justice Services, Pete Carey, Department of Human Services executive director, the Sheriff's Office, Joy Robal, and there's also a data group that we've formed in the community, and as well as a public information officer group. And the public information officer group will also put out a quarterly publication on opioids. Our first publication is going to be very basic. For example, I'm not sure if members of the public know that fentanyl is an opioid and the different types and forms. And then I've been asked some pretty basic questions also that come out of different panels and groups that, well, if I'm going to buy Skittles, do I have to worry about that fentanyl is going to be in Skittles? And so the first publication, and the answer is no, but with that when you're purchasing it at the grocery store, but there are very basic questions I think that people have, and we want to provide unfiltered information to the public as a resource. And we are working with all of our county departments that I mentioned to put out a quarterly publication. So you will be seeing that sometime later in March or the first part of April, and then expect that on a quarterly basis as well. We have some exciting news that we were selected to provide a presentation at the National Association of City and County Health Officials, the Preparedness Summit. Our Emergency Preparedness Program Manager is going to present on comprehensive guide for onboarding new employees into a public health emergency preparedness and response program. It's been accepted for the 2023 Preparedness Summit in Atlanta, Georgia. And I think that's significant, because when you look at our response and how we've managed our team, we are all required to take the National Incident Management System training, and we take that very seriously as an agency. Prepare, and we prepare for the worst and we hope for the best. But this is an ongoing culture within our agency, and I'm happy that we're going to have our Emergency Preparedness and Response Manager present at this summit. We are also going to receive an award, a national award for Project Public Health Ready, and that's an accreditation status for our agency in the realm of public health preparedness and response. And we were the first agency to be honored with that recognition, and this is a re-recognition, and so we will be accepting that award, and I do plan to go to that summit as well. We were also featured in the National Association of County Health Officials, the Exchange, for a best practice as it relates to building partnerships, as it relates to working through COVID, and how you do that is through strategic partnerships. And so I think that was really interesting, because when I pulled up my publication, I go through the agenda, and then I look, and I was like, oh, well, this is very interesting, how to develop and mobilize strategic partnerships. And then I open it up, and it's from El Paso County Health, and I don't keep track of everything that we're submitting or gets accepted. And so that was really neat that I saw our development officer and our public information officer that they were the authors of that. So that was really, really neat to see. That was a few weeks ago. And so now we have a couple of presentations to highlight, and the first one will be, I believe, Becca. It's the Region 16 Opioid Council, and Commissioner Lojinos Gonzalez is a voting member on this council, as well as General Briggs. He is a subject matter expert, and we have a seat for public health. And I think that this is significant as we continue to work towards prevention and substance use and misuse with that we keep this at the forefront of just some updates, because there's a lot of activities that are happening. And so Becca sat in the meeting for me last time, and I wanted to give her an opportunity to give an update, and then also have Commissioner Gonzalez and then General Briggs be able to chime in and also accept questions.
All right, wonderful. Is it on? Now is it on? Oh, now I can hear myself. Okay. So I'm Becca Barnhart. I'm the Youth and Disease Prevention Planner with El Paso County Public Health. As Director Whelan just mentioned, I'll just providing an update today. My role was really to kind of provide some subject matter expertise on one of the prevention, but one of the allowable categories. I'm also not the only representative here today. We have Director Whelan, and we also have Jack Briggs that were there to provide.
And I think Commissioner Gonzalez, you had your deputy administrators at the last meeting, correct?
Before we get started, I'd like to welcome Council Member Tom Strand, who walked in. So thank you for being here.
I participated in all the other ones. I had conflict to get up on this.
Okay, so please fill in a gap if there is an update. But like I said, this is just a broad overview of what the opioid council has looking forward. So the United States has been an opioid epidemic for over 20 years now, and Colorado was no exception to that. Opioid overdoses and addiction have continued to devastate families and communities throughout Colorado. According to CDC, more than 2,400 Coloradans died in opioid overdose in 2020, and some more struggle daily with addiction. The epidemic led to thousands of lawsuits. In 2021, a $26 billion nationwide settlement was reached to resolve all opioid litigation brought by states and local political subdivisions against the three largest pharmaceutical distributors. Colorado secured $700 million in opioid settlement dollars for addiction, treatment, recovery, and prevention programs around the state. These dollars will be distributed to 19 regions, local governments, states, and infrastructure needs, which you can see in the graphic at the bottom right. You can see how it will be distributed. So 60% goes to those 19 regions. Each region is required to create a regional governance council, which was to have to distribute these funds, how to use funds, which programs, draft these funds, etc. The Colorado Opioid Council will work with these councils to put oversight on opioid funds and to ensure the distribution of these funds complies with terms of end settlement and the Colorado Opioid Settlement Memorandum of Understanding. Each state and region will receive these funds for 18 years. The Region 16 Opioid Bank Council consists of representatives from Paso County and Taylor County that work to make our community healthier and safer. These representatives include law enforcement, El Paso County commissioners, including Commissioner Gonzalez, city council members, etc. Non-voting members act in an advisory role include also Public Health Director Susan Whelan, Cal County Health Director, Director of Human Services, and other representatives of any municipality located within either county, such as Jack Briggs, who brings subject matter experts to the council. So in these meetings, we've been working towards setting stage, so defining those expectation, define the 5 allowable spending categories: prevention, treatment, recovery, criminal justice, and harm reduction. Review existing resources, thanks, guys. Oh, yes.
Going back on slide, I do want to highlight one thing. With the documents, there's option for the regards to funding owned. Could it quite efficient? You have large enough kind of program. So I believe every local entity that had the option for the Paso and Teller opted out of that, and so all the money was consolidated just to the region. I think it things more efficient.
Thank you.
Can I answer something as well? Just quick clarification. You did go, so the original funding is actually 2 different settlements. One with a pharmaceutical provider that was just recently to accept that locally, and each on that note that each local jurisdiction has also agreed to kind of put that settlement money into also this structure that already existed to deal with the state opioid settlement. So basically, it's 2 different buckets of money, but because the structure was set up through the state program and the regions, both of those lawsuit settlement dollars are going into the allocation that I think you're going to talk about next.
Wonderful, thank you. So as I mentioned, we work to set the stage, and then we work towards defining the 5 allowable spending categories, which you can see on the left side column there. We went through existing data, strengths, gaps, ROIs, evidence-based strategies to kind of see where's our community at right now, what are we addressing, how well are we addressing that. And then from there, the council worked to generate and prioritize specific spending categories, strategies, or programs. And then finally, allocating those funds to those defined and chosen programs or strategies. Region 16 Opioid Abatement Council met January through mid-March to establish a 2-year opioid abatement plan. $6.4 million was the total amount Region 16 will receive for the first 2 years of the settlement. Estimated total funding over 18 years will be just over $37 million. Again, that's an estimated total. So this is just the first 2 years of how we'll be spending the settlement funds. As of March 3rd, the Region 16 Opioid Council submitted a summary of proposed programs they will fund for the first 2 years with the settlement dollars. The Colorado Opioid Abatement Council will review these submissions early April, and we should receive funding by the end of April. That is the anticipated timeline. As you can see right there, those are the 5. Administrative costs is not one of the 5, but that is something that we have to put money towards. And then you can see the 5 programs or strategies that were chosen by the council after hours and hours of going through data, going through all the existing programs and strategies in our community, and then defining those categories. They also have money allotted to each of those. I put them in order, so youth prevention will be receiving the most funding. Victim advocates will be receiving the least amount. It is not approved just yet. That's why I didn't put the dollars. However, I do have them here if you want to know around the dollar range that we did put for each of those categories. So to dive into each of those, number 1 being youth prevention. This is to support opioid use disorder and substance use disorder prevention, education, and awareness for young people. There are 3 types of prevention. A lot of this will be focusing on upstream prevention efforts to prevent any of this from ever beginning. However, the other prevention categories will also be listed into that. And again, this is specific just to young people. And the next one is community prevention, education, and awareness. There was some confusion that this is the same as the first one. It is not. This one is not specific to young people, first and foremost. It'll be the community as a whole. But it's also to raise awareness of maybe existing programs or strategies that are doing really well, because we do have that in our community, and we should be very proud of that, and we should spend money on really ensuring that people know what resources are available to them, but also providing an education on what opioid use disorder or substance use disorder is. The next one is medication-assisted treatment. This program will provide medication-assisted treatment, also called medication for opioid use disorder, to people with opioid use disorder in the region. The program will include some variation of mobile services so that we can reach those rural part of town, which would be Southeast Southeast El Paso County, and also Teller County. And then recovery support and transitions to support people seeking recovery and transitions, the detox treatment, justice system to community, residential treatment to sober living, etc. Funding can include, but is not limited to, supporting peers, navigators, recovery, community organization development, and crisis intervention. The last one came up actually in our very last meeting, which is victims advocates. This program will provide funding for victims advocates who help surviving family and other impacted support systems of people with opioid use disorder and other substance use disorders navigate the various challenges that arise once entangled with criminal justice system or after the death of a loved one who passes due to opioid use disorder. So think about children that might be losing their family, their parents, and then also those that are spouses of deceased that died due to substance use disorder or opioid use disorder. The next steps, this is the last part, I promise. Once the Colorado Opioid Abatement Council approves Region 16 Council's plan, the council will work through details of each program, such as determining the executive organization and implementation methods. These types of decisions will be made through formal request for proposal process, or in some cases, just a direct allocation to expand effective evidence existing programs. Any questions or comments?
Director Whelan?
Yeah. Thank you, Becca. You did a great job. I mean, we had asked her to represent public health, and thank you so much for providing that overview. I did want to say that my understanding that the chair of the Region 16 is District Attorney Michael Allen. Is there another one? 2 chairs? Or no, but okay. So I did want to mention that because the group is pretty vast. Also, Tom Strand is a voting member as well. We have him in the audience, and so there's voting members, and then there's also subject matter experts and advisory and folks with lived experience, and so the group is pretty broad and insightful, and this has been very thoughtful as the voting members also have thought through and how to structure the group. So, public health is not leading this, but I did want to mention that we will have routine updates as that there's so much going on in our community as it relates to so many different efforts to address opioid misuse and substance use and mental health, behavioral health. And so we'll provide ongoing updates because this council meets routinely. And then I understand with the submission to the Attorney General's office, sometime that will come back in April, whether it's approved or needs to be changed, and then there will be a request for a proposal process that the council, the voting members, will evaluate and then determine where the funding goes. But this is not an opportunity for public health to apply for the funding. That would be a conflict of interest with this, but I did want to make that note that there's still many steps to utilize that funding and put it to action.
Commissioner Gonzalez?
Oh, thank you. And so District Attorney is the chair. There might be some confusion because the meetings were largely run by a third-party company, which was hired to administer us through the initial processes. I forgot what company they are, but that might be the confusion because the individual leading that definitely looked like a chair, the role of the chair, but we had hired a third party to help us get through this process, and they'd worked with other regions that had already been kind of set up previous to ours.
Yeah, and I remember, early on that I believe that Councilwoman Stephanie Finley was the chair, and then there was another one from Teller, and I hadn't attended the last meeting, so I wanted to clarify that. And that group, I can't remember what the group is, they were hired by the voting members of the council to facilitate and not lead. It is the voting members who will make the decisions based on the input from the advisory group, the folks with lived experience to they're gaining a lot of input and insight, and then it is the voting members who have the responsibility to decide where the funding goes and ultimately are responsible and have that authority.
And I'll just mention that part. That took probably 6 months prior to all this, what's kind of making the press now with Teller County, El Paso County, and clearly Colorado Springs being the largest municipality on the makeup of that voting membership. And so that was actually a good 6 months, I believe, of doing that behind the scenes before all this kind of got started.
General Brooks, you have a comment?
Yes, there's a Stedman group, just for the record. And I'm often skeptical, I will be honest, when a large group of diverse folks get together to make a decision, because it can be hard. We end up admiring the problem instead of doing something about it. But in this particular case, it was a very good process. I was impressed with how it funneled down to some decision-making at the end where priorities were laid out and then resources were applied to those priorities. So while I think they got everything they wanted, I think everybody got something they wanted. And I want to highlight back up because it's great to have a bunch of folks in the room that kind of sort of know what they're talking about and then throwing money around at it. Having somebody in the room who knows what they're talking about and can help to refocus not from the art of the possible but to the reality of the doable, I think was very helpful. So thank you, and to the other members of the staff that were there to sort of help with that. I think was very informative. I will say that now that there's some direction and refinement, I think it's incumbent upon us as a board to be asking the staff to keep on top of where this is going, and to start to think about what outcomes we hope to achieve and maybe even have them measured. I think that will be the next thing.
And I echo your comments, General Briggs, also. I mean, Becca has been really just a shining star for our agency, and she leads our youth substance use, misuse prevention efforts, and so that she's does outstanding work. I will say that, you know, our role within this council is to provide subject matter expert and to be a resource for data. And so we have gone before this council and provided insights into opioids and data dashboards and talked through all of that. And as we're working towards data dashboards, you know, getting to your point related to the evaluation, that's what we're you know, focused in on always. And we're very fortunate to have Dr. Mayer and Dr. Albanese, who are just brilliant with data and helping us to translate that and making sure that we get easy access through some of their connections as it relates to some of the data, and then also with our coroner's office. So we are putting together, you know, data around, you know, overdose deaths and overdose deaths and those aspects, but also we want to know, well, you know, what is saving people's lives and how are we, you know, due to the investments that are being made, what's working, how can we measure that? So we will definitely stay on top of that, and I'm hopeful that we'll be able to launch all of those resources to monitor the evaluation for the council in May, and I think that's all I had.
Any other questions or comments?
Can I
Commissioner
just
Gonzalez?
comment on two things? So one thing, I too wanted to compliment the staff and Becca, all the hard work they've been doing. So I just want to brag on them as well. And then I will take the opportunity to brag about the El Paso County Commissioners too. So I said a lot of background the past year. So a year ago when these settlements were being discussed, there was actually an initial draft that would have provided a slightly higher proportion of this funding to the lawyers. And I'll be very honest, the voice of the El Paso County Commissioners saying that more of that money needed to go to the districts and the regions versus lawyers actually helped every county and every region and state receive a slightly higher proportion of funds for programs versus administration costs. So I was very proud of the effort and we did in leading that for the state as well. So thanks.
I wanted to make note of that too. I mean, the structure. Lori Sego's office, the attorney's office, Kenny Hodges, and many were involved to ensure that there was representation from all the municipalities. And I remember having some of those meetings, and that was even happening during the city of COVID, to put forth what is the structuring and making sure that the city of Fountain, Manitou, and all you know, voices were represented. But I just think that I really appreciate when there are groups that come together with I had cons, you know, the LK model and I'm more information and want to be public about that we now there will be there and the town and have it to the public can the town well as can put to
Thank you, Beck.
Hi, quite a lot of can you really want to Stephen what do in the defense speak people like Eric?
Question. This is the I talking better. But I is when you an audit and fit down. Don't talk all the writing the fielder. Even the upstream to help that as well. The extreme that well is. And next to subject special there and typing words back to the scene until come today have us to complaint. But there are so many actors that have look and fight and putting for to that. So these are within bleach education political or looking for to get more blood or for to get one of our initiatives. We let to the old we provide locks to face and we also push for take we keep those substance out of the custody all bearing care and oxidating those medicines the face now because crime or cells you with the house bring rams reasons for people but they can net their into a ram the bike RJ health center may spend 9 hours going to spend day or grow up I was going to see that's sitting the stuff by it is a lot of I mean they're doing our me until I that all about something for tax better look at that is really stuff out real hard to place into Brazil week with street or region and the types main community still except we have shopping pizza then for the people there be so there's our specific ram too. I'm thinking what it's word using the quite thing or biggest population thing open to anything to pay quote not I'm not subject to them and no young auditing able and their double unity know the works big type of no population setting in there isn't and young sin as of a dream Scott Joe or the all into you said our says on profits go up for that for in so
Shigella can be treated. There are antibiotics that historically can be used either to shorten the course of an illness in someone who's infected, reduce their chances of spread because it reduces the amount of bacteria that you have in your intestines, or if you have particularly severe or prolonged illness, those would all be reasons you want to treat with antibiotics. Next slide, please. So again, what do we worry about in our program? We worry about the risk of an outbreak occurring in close contact settings. So you can get a Shigella outbreak in a child care center for sure. You can have it in in really any close contact type setting in shelters, other institutionalized settings. For some individuals, this diarrheal illness can be quite severe. If you have underlying health conditions and you get Shigella, you're going to be in pretty big trouble. May land yourself in the hospital, and your infectiousness and your diarrhea can last for weeks. There are some very rare complications of Shigella, including joint pain. It can break into the bloodstream and give you a blood infection. And a very rare complication in children is actually kidney failure. Of course, that's something we'd like to avoid. Next slide, please. So how did this end up in the media coverage? So these are a couple of local media coverages. On the left is that. On the right is our senior program manager, Haley, doing an interview for KRDO. And this was around drug-resistant Shigella cases. So this has been not a brand new issue for Shigella, but there's been a marked recent change in the trends of drug-resistant Shigella that had landed some warnings from the CDC, particularly for Colorado, that we dealt with over the past few weeks. Next slide, please. So over the past decade, Shigella bacteria have been developing resistance to an increasing number of very commonly used antibiotics. And so that in and of itself is a problem. So back in the day, so on the left graphic, back in the day, we used to treat Shigella with amoxicillin. Yeah, good old amoxicillin, or Bactrim. And if you had children, those drug names probably sound familiar. But now it's a no-go, right? At this point, from national data, about 77% of the Shigella bacterial strains are resistant to amoxicillin, about 66% resistant to Bactrim. So then we switched to sort of a next line of antibiotics, one called azithromycin, also called a Z-Pak. Cipro is ciprofloxacin, but again, over the past decade, you can just see those trend lines. The 2023 don't just ignore the downside, that's just our data is not all collected yet. But basically, our second-line antibiotics of azithromycin and ciprofloxacin also increasingly becoming resistant. Next slide. But what really hit the news is what they are now classifying as extensively drug-resistant Shigella. So like the big Shigella that really have developed resistance to all commonly recommended antibiotics that we used to use to treat this infection. So national data, you can see this trend line and the percentage of the estimates that are calculating nationally for the percentage of the Shigella bacteria that is extensively drug resistant. And you say, well, now in 2022, 5%, that doesn't sound like a very big number. But if you look at that trend line, that's all in the past couple of years. So that is not a good trend. So in essence, if someone is infected with one of these strains of Shigella, you are kind of out of luck. You're now talking about very unusual drugs that you have to try to find in order to treat this individual. You're talking about extensively drug-resistant Shigella that is very easy to transmit, doesn't take a lot of Shigella to spread it from one person to another. And so depending on the infected individual and their environment, you could potentially have this very drug-resistant strain getting passed around very easily. And so this is what prompted the warning from CDC and within Colorado. Next slide, please. So we are on this map not for a good reason. So this is the cases of extensively drug-resistant Shigella species reported in the United States since 2015. And we're on this map for the wrong reason. The darker shade or blue are the more cases that we have reported from a particular state. So California, Colorado, Texas, and Massachusetts kind of rising to the top. I don't think this is really a characteristic that Colorado would like to have us have a claim to fame. Next slide, please. So in fact, with the national data, Colorado has the second largest number of drug-resistant Shigella cases in the United States since 2015. So this has prompted, obviously, a report from CDC, obviously a warning sign for us in the communicable disease world in Colorado. So in 2022, there were 32 extensively drug-resistant Shigella cases in Colorado. They were identified in 3 outbreaks, again, hence concern that you can have an individual with this infection and it just can get passed on and create an outbreak depending on the setting. And we've had 3 of those cases occurring here in El Paso County. So this then ties us all back in why we were contacted by the media. Next slide. So we need to do something about this. And so over the past weeks, There have been a number of advisories that have gone out to particularly to our healthcare providers, because they are going to be on the front line to try to identify patients who might have Shigella infection, and so to sort of provide them guidance in terms of when to, Shigella is in the stool. There's appropriate testing that needs to be ordered in order to diagnose this infection. Because of the issue with antibiotic resistance, some providers would never think about antibiotic resistance. Now they do, and we need to make sure that they are ordering the right test, to detect that. You use those test results then to guide antibiotic treatment decisions. And if you have a patient who has extensively drug-resistant Shigella, this is going to be a consultation probably all the way up to CDC to try to figure out how to manage that patient. Infected patients need to be counseled about their risk to other individuals and the fact that they can spread it to other people. And again, depending on the setting, on where that patient lives and works, we have to be very cognizant of that. We have to remind our clinical laboratories in our state to be sending specimens that test positive to Shigella to our state public health laboratory. That gets forwarded onto CDC so that we can do this testing for drug susceptibility. And then, as we are going to describe with Emily, we have a local health response to any Shigella that occurs in high-risk settings. So it's not that we are waiting to see if it's drug-resistant and then we respond. No, we get a Shigella case, and right up front, jump on that and figure out what happened, who is it, what's the setting, what's the risk of spread, and then we move. The antibiotic data comes later, and we need to be up front right from the beginning. So I will ask Emily Marshall, our community police epidemiologist, to let you know about some work that we had done with an outbreak here in the county.
Thank you, Bernadette, and thank you for having me. So I'll be presenting just a couple of slides about our actual work on this pathogen in an outbreak of shigellosis amongst persons experiencing homelessness in the county. And this really started around September, when we began seeing a sudden increase in cases of Shigella. Typically in a year, in the last 5 years or so, we would see around 11 cases of Shigella a year. But in 2022, there were a total of 57 cases that year. And once we've done the outbreak investigation, we were able to attribute 27 of the 57 cases to the outbreak. So nearly half of the cases were related to this incident. The outbreak is defined as starting on September 2nd, 2022. That was when the very first person began experiencing illness, and it ended on January 17th of this year, when the very last person started to feel ill. Next slide, please. So we became aware of this outbreak on September 12th of 2022, when a infection preventionist from a local hospital informed us that there was a case of Shigella amongst a person experiencing homelessness. We routinely receive reports of people who are positive for Shigella, but this infection preventionist had the wherewithal to consider that this is a high-risk individual and there could be more to look into here. So as we conduct routine investigations, we did learn that this person knew of other close contacts who had the same type of illness, all related to one homeless encampment, a very large homeless encampment that we were learning about. So we actually went out in the field and visited that location 3 different times in September and October with the accompaniment of the Colorado Springs Police Department Homeless Outreach Team. And we brought with us hygiene kits. So that was like our peace offering and a mode of actual prevention. We were giving them hand sanitizer, wipes, toilet paper, things like that, while we also were able to engage with them in conversation about what Shigella is, what the symptoms are like, how you can prevent yourself from getting it, and if you're sick, please use these items to prevent other people from getting sick. So we had those one-on-one conversations and gave educational materials, as well as our communication, our contact cards, so that they could let us know if they were sick. Because the idea was to get them out of that homeless encampment where spread would become really, really easy, and get them into a shelter where they could isolate, which we did for 11 individuals. They were provided shelter where they had a private room and a private bathroom so that they could recover more comfortably and reduce the spread to other people that would more likely occur in that homeless encampment. But the greatest takeaway from this experience was really the partnerships that we built with agencies in the county that serve people experiencing homelessness. We, connected with all of the local shelters to inform them about this outbreak. We asked them to give us a call if they saw anyone who was sick, and some of those 11 people that were placed in the isolation shelter were found from presenting at other shelters where they were ill. So we really strengthened that partnership and made them aware of our resources, put kind of a name to a face after the pandemic, and let them know that we really are working hard to address this vulnerable population. So we've been invited to their roundtable meetings, and we're still a part of those to kind of inform what the latest happenings are amongst persons experiencing homelessness in the communicable disease world. So there are continued efforts about this outbreak, though it's done. We're writing summary reports. There's a lot of presentations just like this one still happening because it was not only really interesting, but a great success in our efforts that we collaborated with. There's a thing to prevent a lot of illness. Shout out to Brenda for having us with, Dr. Albanese, and my partner on outbreak is Shane Fossey in the back. She's a disease intervention specialist. She and I really spearheaded this outbreak, especially those field workers. It was a really, really productive outbreak, and hopefully we'll see nothing soon. That's all.
Any questions about Albanese for Emily, Dr. Booth?
Thank you, Dr. Albanese. Can I ask, it sounds to me like at this time, then the state lab will do antibiotic susceptibility testing for all samples positive for Shigella. Is that right?
Dr. Vu, it's a little more complicated than that. We actually want the providers to use the typical clinical laboratory and order it and have it done the traditional way out of the microbiology laboratories, in the hospitals and commercial laboratories. The Shigella bacteria that are sent to CDC then have, and again, I can use like all these words now because of COVID, molecular testing and strain typing done, and then through that, so they sequence it, right? They do the genetic panel of the organism, and then they use that information to extrapolate the resistant patterns, because not everybody, so sometimes we get specimens sent to the public health laboratories that never got antibiotic testing done. So it's like, I don't know. So we'll send those to CDC. They'll run those molecular panels and that genetic testing, and then we come back and say, based on those genetic results, we then estimate that, in fact, they were antibiotic resistant, but the provider actually didn't know. We're trying to get ahead of that and have the providers order that antibiotic test right from the get-go so they can do the clinical management piece. And then because if we have that early, because we can see those results as well in public health. If we get that right up front, then we amp it up another level. I mean, we're still, jumping in and trying to do our disease control, but if we know right up front it's antibiotic resistant, we can get messaging out a little bit quicker and so forth. So we're trying to have the clinicians work with us to get that testing ordered right up front. But it is from the regular hospital and commercial labs. Will get us what we need. Because, they're looking for amoxicillin and Bactrim and ciprofloxacin. Like, it's pretty straightforward stuff from a testing.
Any other questions or comments?
Yeah, it sounds like the initial susceptibility testing is done through PCR sequencing. Is that right?
They'll actually, I don't want to get like technical for the group, but they'll do the antibiotic susceptibility testing the traditional way in the microbiology laboratory for the common antibiotics. Like they can do it the traditional way for, like I said, amoxicillin, Bactrim, azithromycin, and Cipro. And then the specimens will go to CDC where they can do expanded panels. They can sort of compare sort of strain matching across the country and that kind of stuff to sort of just look sort of higher level to look at transmission patterns and so forth. But the clinician needs to know, can I use amoxicillin to treat this patient? So most doctors would just say, that's what I would go to. But now they need to pause and say, no, I need to order the test, see what the results are, and then get to pick what medicine I need.
Okay, so that was leading to that. So do the clinicians need to additionally order an antibiotic susceptibility test in order for that to be done, or is it automatic?
No, it has to be ordered. So they have to order a stool culture, and they have to order an antibiotic susceptibility test. That has to be done proactively. It's not a reflex.
Okay.
Yep.
Thank you.
Dr. Albanese, what's the turnaround on those tests so that if you've got
48 hours.
Okay.
It's quick.
Quick. Okay, thank you.
Yep.
Any others? Council.
So I obviously have two hats in this conversation. I'll put my rescue mission hat on first to say that, we do really appreciate the early and often engagement that we had with the staff on this. Now, I'm going to put my board hat on here for just a second. I think there's a repeatable process here that will be useful in the future for other issues. When these things first come up, they can be treated as a crisis, which leads to panic and all kinds of different things that people get pretty worked up about. That did not happen here. Instead, it was transitioned to a problem that needed to be fixed, because you don't fix crises, you fix problems. And so I appreciate that very much as well. I think the procedure, doing it over and over again, will turn these problems into just issues. And as we see success in addressing issues, they just become day to day. And that's what we're trying to do. I'll put my rescue mission hat back on here for a second. That's what we're trying to do at the rescue mission, is to transition from having this either be a problem or an issue to just something that we're monitoring day to day. And I think that's where, once we got into that mode, you started to see the decrease in the numbers that maybe our clientele might have been contributing to. That doesn't mean that we reach out into the camps, though. We try to educate out there, but that's the next thing. That's the next step. So I just a shout out to the team that I think we're creating what can be a repeatable process.
Thank you. Councilman Donaldson?
Yeah, thank you. So 57 cases in El Paso County in 2022, is that right? And then 27 of them were in this one outbreak. The other 30, can you go into that a little bit?
So the outbreak in total actually had 32 cases, but they did span over into the new year, 2023.
Mm-hmm.
There are routine cases of Shigella that do happen, many associated with travel, international travel, people coming back from different countries, they're sick, and we do mark that in our investigation where it was acquired. So internationally is pretty normal, but this is routine. There are, on average, 11 cases a year, though we are seeing a higher rate outside of the outbreak. That's systemic over a bunch of states. It's not Colorado specific. It's something CDC is looking into. What is the cause of this? Is it foodborne? Is it person to person? What are some implementation factors we can have there? So yes, we did see more cases than normal regardless of the outbreak, but there was not a secondary outbreak that's responsible. This is pervasive over other states as well.
The 11 that we usually get, are they usually in people living in these camps? Homeless people?
I can't give you an exact number on that, but it would be, possible, but not necessarily a staggering amount that are just amongst persons experiencing homelessness.
I guess you're gonna get the actual numbers, but would you say it's at least
Sure.
half of them are typically?
I can't say.
What other groups are the susceptible groups that you see more people coming from? Travelers, that's a good one. It's not random.
Traveling, and again, sometimes you have cases in a child care center, persons experiencing homelessness, transmission, sexual transmission is another category.
Okay, that's helpful. Why do you think it's us in California with these large numbers of the resistant, the broadly resistant Shigella? Is it Californians that have moved here?
Yeah, you got to remember too. So those were not rates, right? Those were counts. So California has 30 million people, so they're going to have a lot more of a lot of things. I think in some ways we're sort of disproportionately high for the size of our population. So I think it's some of these may be driven. So in Colorado, those 32 cases were across 3 outbreaks. So again, I think if we could have removed the outbreak spread, we probably would have had lower counts. But so I can't speak to California, but I think this is the extensively drug resistant is a relatively new issue over the past year or so. So I think we're trying to figure that out. But I think when you have it spread in outbreak settings, then that's going to pretty rapidly.
Dr. Albanese, do you know, is it mostly in San Francisco and California, or disproportionately in San Francisco?
I do not know the answer.
Were those, what do we have, 30-some cases here in Colorado? Is that mostly in Denver?
Let me get back to you on that. I mean, again, a lot of things happen in our population corridors, which is basically I-25 corridor in Colorado. So, so we're not adjusting this for the size of the population. So the cases are probably going to occur where more people live.
But it could be among farm workers who are, picking crops, and their sanitation is not as
Yeah,
nice as we have in Colorado Springs.
Yeah, I mean, this is a person-to-person illness unless that person contaminates food or unless that person contaminates water. But basically, it's primarily a human.
Any hospitalizations here in Colorado, or in the Springs, or El Paso County?
I can speak to the outbreak. There were 7 hospitalizations total, no deaths.
And the 3 that we had here that had the extremely resistant, what kind of are they quarantined? Or we ask them, hey, stay home until you're testing negative or everything's gone back to normal? What do we do with those folks?
Sure, everybody, we think like it's very illness. You go to the restroom, it's on your hands. That's how it works. So we give them that. I mean, sure, but that's what it is. We try to do that basically. If they work testing, then we can go for free. We'll be strict. They will get follow-up testing for go back to our private health worker, we will restrictions depending on the setting. Otherwise, there's only like traffic members. Try to use every don't hand food. You gotta wash your hands. Sit. And we'll provide all of that.
The case is really recently they don't remove directive guidance.
Fact out food, they came out of fact. I just said that once that's not there, got to genetic out later, and so that's why better help during and back on tonight and divine later. So this is someone's retro about
that level of testing. They'll have to some isn't low. Find out if it's a cog.
You can get those 10 laboratories like the characters I mentioned. They got to get sort of general sense, but the more space that comes to the regular at this point,
we won't.
I'm not rid of that, but we would do the general answer a little different, but only
just try to clear it on the final question. Back to your is ditto. Whether you have to ask you more.
It's working. So the emergency thing, you hide it, but it's simple, no problem. And no experience in the rest, but fish use on their hand to help. And psych openers a way to prevent successful living when it prevent some use business. And we keep the bond around now we do funnel work. What we so much you can do it. The emphasis of men as it's to they're set up the paint for we are in with certain ways in the grass and equal. And like my topic seeks the it is that near rain on your hand. So we just do like about when you're when you can really happy they sort of see really good Josh hand keep yourself and not from show up just that's approaching and as you put it now I'm certainly wearing on the back to more and that's why you allow divide the gene say call one for sensors our outspurs out of do in or on a kind of track we're doing anything if after to rest that does have part of the word washouts or so that's problem and see we have other currently just some 6 minute medicine which talking to question
it's just like the drugs and drugs system is and drugs
if we had a public perspective then principle keep water hand big side shadow allowable that or this around injury and not a no level or wasn't steered of stage so I stand for you people it's I wouldn't probably be releases there oh is real careful there's a look at the shadow living in it those not but you know I walk a future over way and there's feast in the group at several both you fight a bit better setting.
And what's the book is no asset time on to choose based maybe much more like not ready to bam or age so phone the president ask care new matters line it could be produces to the first targets be so you can do so I just share all of it argent is torch that you could get this and appropriate
are there other questions you should thing that you
Thank you. I 5 weeks now. I had to I did part of the original thing of you help and then to be a source and things that today but way CD and I've involved that way and just in there set that one old ODD the one and lazy file to have your general and lead conversation with LP on that and honor kind of new works that alongside Pat Downey and I'd get up even told I delete up job get ahead over it I invite 2 competent chairs those factors it was small score see more healthcare to the Patrick cares much hustle around and teenage cleaner 40% was data share and I'm kind of like a great we've been long actually and it was just some hours that are really out of it
any comments you ask in turn sound like the Lord going mistake Rex sound to help and look up men's of you question turn Councilman Lincoln South All